I'm Scott Delacroix. I'm a urologic oncologist from Louisiana. I work at Mary Bird Perkins Cancer Center. I specialize mostly in treating patients with bladder cancer and prostate cancer.
My name is Himanshu Nagar. I'm a radiation oncologist based in New York City at Memorial Sloan Kettering Cancer Center. I specialize in all genitourinary malignancies. So NRG-GU015 is named Archer, and it is a randomized phase 3 trial comparing two different types of radiation treatment regimens. The full title is Adaptive Radiation Therapy and Chemotherapy for Muscle Invasive Bladder Cancer. And the fundamental question of the trial is, can we deliver abbreviated courses of radiation therapy with chemotherapy for muscle invasive bladder cancer and not affect patients' ability to keep their bladders or lead to greater toxicity?
So from my standpoint, it's a very simple question. It's asking, doing what we normally do with bladder preservation, which historically we've done 7 weeks of radiation. Taking that down in the interim since our last trial, which was NRG-GU015, that was 7 weeks of radiation. And patients really like the ability to not have their bladder removed and try to preserve their bladder. So this trial with new data that's come out is actually testing 4 weeks of radiation, which is 20 treatments to the radiation center, versus going for 5 treatments. The overall dose would be comparable between the two. You're just giving a higher dose on 5 different treatments. The benefit of that for the patients is a lot of our patients travel far distances. In Louisiana, we have a lot of rural patients. A lot of patients will travel from all over the country to go to see Dr. Nagar in Sloan Kettering. And if you could go for 5 treatments versus 20 or 42 treatments, it makes a big difference on how many patients we can access, treat, and try to provide a cure for. So this is a very patient-centric question that we're asking.
So one question is the technology available, because in the title and the purpose of this is an adaptive radiation treatment, but we are being very permissive in terms of technology allowed. So depending on what type of linear accelerator you have, whether it's the most advanced technology or those that are just standard in most radiation centers, all technologies allowed on this trial. So we have plan-of-the-day options, adaptive options. So this is meant, as Dr. Delacroix mentioned, to be available to all patients that are at any radiation center. The other question that we commonly get is, can patients have therapy before and after? So what we're allowing is being very permissive in terms of any neoadjuvant therapy, whether it's chemotherapy, immunotherapy, and similarly after the radiation chemotherapy is done, because we want this trial to be as pragmatic and stay up to date as the treatment landscape evolves, which it does quite a bit recently in the bladder cancer landscape. So we want this trial to remain pragmatic even during the duration and after the trial is completed.
If a patient in rural Mississippi, rural Alabama, rural Louisiana can come to our center, see us, potentially receive neoadjuvant chemotherapy, then when it's time, go ahead and get trimodality therapy and come for 5 treatments. That's a game changer. It's financially very big for the family. A lot of these patients are older, so the family is transporting them. And it's interesting that about 20 to 30% of patients, especially in more rural locales, who have muscle invasive disease, which at the time of diagnosis could be cured, to decide to not get curative intent treatment because the treatment is either too intense, they don't want to have their bladder removed, or they can't go to a radiation center and see a specialized team for that duration of time. This hopefully will change that for those patients.
So what's embedded in this trial is a lot of translational biomarker information. So we partnered with several companies here to not only understand, to answer the fundamental question of the trial is, can we shorten this safely and effectively, but also can we learn from various biomarkers, whether it's urine or blood, ctDNA, or the tissue biopsy itself, to further prognosticate and predict how patients will do. So even though the trial will ask a major question of, can we safely shorten the duration for these patients in terms of treatment intensification, but we're going to learn a lot about the biology behind bladder cancer for these patients.
Sure. From a physician standpoint, it's very pragmatic. The way this was written has very large windows because we know that these patients tend to be more elderly. They come to our clinics a month, 2 months after diagnosis and then decide, okay, I'm looking for treatment. So having something that was a very short window, that was a perfect trial from a timeline standpoint would really cut a lot of patients out. So the windows are quite large. ctDNA testing done by Natera is provided on the study for the patients once they enroll, and it's actually longitudinal, so they'll get them throughout the study. It's a true multidisciplinary collaboration. So it has really been partnership with radiation oncology, urologic oncology, medical oncology, physics, radiation therapists. It's been a team to put this trial together. And I think it's one of the first adaptive trials
It's the first
for NCTN. So we're very excited. And I know patients are excited.
And we have a very strong patient-reported outcome team that is embedded within this trial also, because it's not only about the effectiveness of the therapy, but how patients feel no matter which arm they're randomized.